Good afternoon, everybody. This is Irma Rukhadze, an associate professor at Albany Medical College, joining this wonderful conference today from Albany, New York. And it is my absolute pleasure to talk about the research performed in my laboratory that is focused on neuronal underpinnings of obstructive sleep apnea. And the ultimate goal of our research is to identify the therapeutic targets that can be used to develop the pharmacological treatment for obstructive sleep apnea. Obstructive sleep apnea is included in the list of common sleep disorders as outlined by American Academy of Sleep Medicine and other societies, and it is a common sleep-related breathing disorder which is characterized by cessation or complete stopping of breathing during sleep due to upper airway obstructions. Obstructive sleep apnea is affecting individuals with anatomically compromised upper airways. On this slide, we can see the MRI images of normal subject with fully open airway versus the narrower upper airway identified in patient with obstructive sleep apnea. This can be due to the anatomical abnormalities that individual is born with or developed later in life due to the obesity, which results in fat deposition, and it is depicted here as a white area in the neck region and the lingual area, and the fat deposition further narrows the upper airway and makes it prone to collapse during sleep due to the muscle atonia. Genioglossus muscle, which constitutes the most tongue muscles, is a fan-shaped muscle here and abbreviated as GG, and it is the main upper airway dilator muscle, which plays a critical role in maintaining upper airway patency. The elegant study performed in 1992 by Dr. White and colleagues identified that the genioglossus muscle activity is significantly increased in obstructive sleep apnea patients versus normal controls during wakefulness, and this has been seen as a compensatory mechanism to overcome the anatomical abnormalities during wakefulness and keeps the airway open. However, genioglossus muscle activity is decreased at sleep onset, and as we can see on this polysomnographic recording, during wake the GG is active and then reduced the activity in stage 2. Sleep further reduction is noted in stage 4, and it is absent or atonic during REM sleep. Atonia in genioglossus muscle is a main cause of developing apneic or episodes during sleep. Apneic episodes can happen hundreds of times per night, which is extremely disturbing to obstructive sleep apnea patient experiencing this disorder. This is a polysomnographic traces from very detailed experimental study performed in severe obstructive sleep apnea patient, and the expanded image one of the apneic episode shows the genioglossus muscle activity, submental muscle activity or EMG, electromyography, electroencephalography, the epiglotic pressure, the nasal flow, and the level of oxygen saturation. The apneic episode we can see here is accompanied by complete absence of the airflow, and despite the progressive increase in genioglossus muscle activity, the episode could not be ended without arousal from sleep or awakening. The arousal from sleep is leading to sleep deprivation chronically experienced by sleep apnea patients. The very important also to notice here and critical is the drop of blood oxygen level, which is called hypoxia. The hypoxia is followed by rapid reoxygenation caused by arousal. So hypoxia, cyclic hypoxia and reoxygenation can trigger the oxidative stress, inflammation, and other physiological processes that contribute to the development of health complications associated with obstructive sleep apnea, and they are pretty deleterious conditions, one of them being neurocognitive disorder, cardiovascular disorder, metabolic disorders, and neurodegenerative disorders. Also, this last decade, there has been studies performed showing that the obstructive sleep apnea due to hypoxia and sleep deprivation can exacerbate the progression of cancer. The treatment options are limited for obstructive sleep apnea, and the golden standard remains still continuous positive airway pressure, which is not well tolerated in many patients. However, this is the best choice non-invasive approach to alleviate those symptoms experienced by these patients. Other treatments include the invasive surgical approaches, which is hypoglossal nerve stimulation, mandibular advancement, and the recent development also shows promise to use the pharmacological treatment for weight loss, which is helping the obese obstructive sleep apnea patients. What predisposes individuals to obstructive sleep apnea? There are several risk factors, and they are listed here, mainly obesity, the facial configurations, the large neck circumference, alcohol consumption, smoking, hypothyroidism, and aging, which is independent risk factor for obstructive sleep apnea, and the prevalence significantly increases of this disorder with aging. The critical here is the reduced upper airway muscle tone during sleep, as we have just discussed. It is a major contributor to upper airway collapse, leading to apneic episodes. And gender, it is well known that obstructive sleep apnea affects more male individuals than women's. What are the signs and symptoms of obstructive sleep apnea? There are several, and if we experience snoring or choking during sleep and other symptoms listed on this slide, we may consider to consult with a sleep medicine doctor and probably get done this sleep study. The obstructive sleep apnea comorbidities are different depending the age and sex of the obstructive sleep apnea patient. This very elegant study performed by Dr. Kozal's group clearly shows the sex dependence and age dependence of the comorbidities of OSA, and mainly here diabetes, the metabolic disorders, for instance diabetes type 2 is more seen in male patients with aging than in females, and for instance hypertension increases also with age. However, the ischemic heart disease is more observed in males with aging, and the only clear differences affecting more to women than males are mood disorders or depression, if you wish. So what is the neuronal mechanism behind the either age or sex dependent prevalence of obstructive sleep apnea remains still not well understood. The obstructive sleep apnea patients can be also living many years without a diagnosis, which is another risk factor for developing those comorbidities. And it is a highly prevalent disorder and the major health care issue. And on this slide you may appreciate how many people in these countries are affected. The worldwide, almost 1 billion people is affected by obstructive sleep apnea, and many others can be living without diagnosis. The main focus of my laboratory is to identify the therapeutic targets for developing obstructive sleep apnea pharmacotherapy. And I'm doing this research with Dr. Victor Fennick, who is a co-director of my laboratory. The main research performed in my lab is looking at neuronal mechanisms underlying the pathophysiology of obstructive sleep apnea, what is causing the age-related increase in OSA prevalence and gender differences in OSA prevalence. We are also interested to identify how obstructive sleep apnea contributes to age-related cognitive deficits and neurodegeneration, and we are hopeful that our research can help developing pharmacological therapies and the personalized treatment to improve the quality of life of obstructive sleep apnea patients. So to do this research, of course, to identify the effective therapeutic targets and develop the pharmacological treatment for obstructive sleep apnea, we need to fully understand the neuronal mechanism that is underlying the sleep-related depression of upper airway muscles leading to upper airway closure experienced by obstructive sleep apnea patients. So different neuronal populations of the sleep promoting and wake promoting neurons form this flip-flop switch circuitry that results in rapid and complete transition in behavioral states. On the left side on this slide depicted are many neuronal populations in the brain, and the wake active neurons are the ones that shown here as NA neurons or noradrenergic neurons, for instance in locus ceruleus, but there are other noradrenergic regions also in the brainstem that I will talk in a minute about, and the serotonergic raphe neurons or exergic lateral hypothalamus neurons that are firing at maximum during wake. These neurons cease their firing at the onset of sleep, and some of them are virtually silent during REM sleep. So we were thinking maybe this state-dependent activity in these neurons contributes to state-dependent depression of upper airway muscles during sleep. On the right side here, we on the image we have the 12 or hypoglossal motor nucleus, which has the hypoglossal motor neurons that innervate the genioglossus muscle, shown on this middle image here in the human tongue picture, and the hypoglossal motor neurons or dorsal root of the hypoglossal nerve is exclusively innervating the genioglossus muscles. So the question is, do the sleep active or wake active neurons that have decreased activity during sleep innervate any upper airway muscles, or at least the genioglossus muscle, which is the main upper airway dilator muscle? So we have performed series of neuroanatomical studies, and we have identified that as we can see here on the slide, image A has a blue circles and sphere in the brainstem that shows the PPT or pediculopontine tegmental nucleus, LDT laterodorsal tegmental nucleus, and IRT, which is intermediate reticular formation, and they are rich with cholinergic neurons, or they are called the cholinergic regions in the brainstem. And in our neuroanatomical studies we found that they are providing innervation to hypoglossal motor neurons, they're shown as on image C here on this slide. And the hypoglossal nucleus is marked here as 12, and hypoglossal motor neurons further innervate the genioglossus muscle, which we successfully record in mouse model of obstructive sleep apnea as shown in image B. So the other neurons that we have identified provide the innervation to hypoglossal motor neurons are shown again in image A here in red spheres, and these are the noradrenergic neurons of the brainstem, which includes locus coeruleus, of course, and there is A7, subcoeruleus, A5, and A1C1 in the medulla, all of which we have quantified their contribution to hypoglossal motor neuron innervation, and they are providing their excitatory, vague active excitatory drive to hypoglossal motor neurons. However, we know that the noradrenergic neurons are silent during REM sleep, and the question was whether these anatomical projections are also functionally important for the activity of upper airway muscles. We're not included in this talk today, but we have followed up with a number of functional studies, and we have identified in vivo models of rodents that the noradrenergic neurons are critical for maintaining upper airway muscles, and also the cholinergic neurons have been identified to contribute to state-dependent control of upper airway muscles. So that anatomical studies followed by functional studies partly from our laboratory, and identifying the noradrenergic system, at least 50% responsible for upper airway collapse, and another 50% identified by other group of investigators are the cholinergic neurons. So based on these critical animal studies, the clinical study has been designed by Dr. Wellman and his collaborators at Harvard Medical School, and they identified the combination of atomoxetin, which is norepinephrine reuptake inhibitor, and oxybutynin, which is cholinergic antimuscarinic agent, greatly reduces obstructive sleep apnea severity, which was a groundbreaking study and also providing the proof of concept that the findings from animal studies are relevant and critical to inform the translational or clinical studies. The slide on the left side shows the apnea-hypopnea index in placebo group and atoxy group of obstructive sleep apnea patients, and we can identify easily that the significantly decreased number of apnea-hypopnea events in atoxy group. These agents has been also tested separately, and it is shown on the right side of the slide that we have a placebo group, and again the group data from atoxy combination, and then oxybutynin and the oxybutynin and atomoxetin is the last bar here. Interestingly enough, separately, these agents did not significantly decrease the apnea-hypopnea index, but again, this is suggesting that the both neurotransmitters, norepinephrine and cholinergic, are necessary and critical for state-dependent activity of genioglossus muscle. And further, we can suggest that the state-dependent activity of GG muscle is in part, at least approximately 50%, controlled by brainstem noradrenergic system. So Since the brainstem noradrenergic neurons are the main state-dependent excitatory inputs to hypoglossal motor neurons, we hypothesize that the chronic intermittent hypoxia, a major component of obstructive sleep apnea pathogenesis, may degenerate the noradrenergic drive to upper airway muscles, which would exacerbate obstructive sleep apnea and significantly contribute to major comorbidities associated with obstructive sleep apnea. To address this question, we use the transgenic mice, which is commonly used in our research, and this is a mouse that expresses Cre recombinase in catecholaminergic neurons, and this is a DBH-Cre mouse, which has been rigorously validated in our and other labs. And on the right side, top part of the slide shows A7 and subcerebrous noradrenergic neurons, which are co-expressing the Cre-dependent gene. The red neurons here are also labeled for green, which was for tyrosine hydroxylase, which is a marker for noradrenergic neurons. So co-expression of TH and the Cre-dependent gene shows us the highly selective line of this mouse, which has no ectopic expression and is very selective. So this is a reliable transgenic mouse that we used for injections of Cre-dependent anterograde tracer channel rhodopsin, which is also fused with cherry red fluorescent protein that helps us to identify the expression of channel rhodopsin in TH noradrenergic neurons. The mouse injected in A7 region, which we can see the bottom left side on the schematics of the brain here that we aimed our injections in A7 region. After injections, they have been subjected to chronic intermittent hypoxia, and the right bottom part shows here the oxygen profile in our chronic intermittent hypoxia chambers, where our mice has been housed for 35 days. And this is an animal model of obstructive sleep apnea, the only animal model which closely mimics the hypoxic events experienced by obstructive sleep apnea patients. So we use the 10% drop in oxygen level, which is to our knowledge very closely recapitulating the hypoxia or oxygen desaturation experienced in obstructive sleep apnea patients. So in this mouse, after 4 weeks of channel rhodopsin injection, which is a sufficient time for maximal expression of this tracer in neurons of targets, in our case in A7 noradrenergic neurons, we perfuse the mice and confirms the expression of channel rhodopsin in noradrenergic neurons, and we identified that noradrenergic A7 and subsyn neurons are transfected with channel rhodopsin, and they provide the axonal projections to hypoglossal motor neurons. So on the top panel here, the very left shows the region of A7 and sub-C. Of course, the target region was A7, but they are very close, neuroanatomically very closely located regions, and it is inevitable that the injection in A7 often spreads to subcerebrous region, and they both get co-transfected because both of these neurons in both nuclei express Cre recombinase, and our Cre-dependent channel rhodopsin is successfully transfected them. So the next high magnification image in red staining shows the channel rhodopsin expression, and the green only image shows the tyrosine hydroxylase positive neurons, which are the marker of noradrenergic neurons in A7 and sub-C, and the right top image is showing the co-transfection of TH neurons or noradrenergic neurons, if you wish, with channel rhodopsin. The bottom panel is showing the on the very left is the hypoglossal nucleus in this mouse, and abbreviated here as a 12, and the dashed lines overlies the hypoglossal nucleus left and right side, and the higher magnification images here in red show the red stained axonal projections from the channel rhodopsin transfected neurons from A7 and sub-C, which are also positive for TH, and in the yellow arrow here showing the TH positive axons, and they are double labeled on the right side image. The TH positive axons are expressing the channel rhodopsin. This way we confirm that the A7 and subcerebellous noradrenergic neurons do innervate and send dense axonal projections to hypoglossal motor neurons. However, because we had transfected both noradrenergic neuroregions A7 and sub-C, we wish to identify which of them are the showing the clear relationship between channel rhodopsin transfected neurons counted in A7 and sub-C and the number of axons counted in hypoglossal nucleus. So as we can see on this slide, the number of sub-C neurons transfected with adeno-associated viral vector channel rhodopsin strongly predicted the density of noradrenergic axonal projections to hypoglossal nucleus, and the left image on this slide shows the significant correlation between axon counts and number of transfected noradrenergic neurons in subcerebellous region, which is not the case for A7. They show weaker correlation, not significant, which may suggest that they do project, but may not. But these projections may not be direct. So furthermore, we wanted to identify the effect, of course, of intermittent hypoxia on these projections, and we have counted the number of axons originating from A7 and subcerebellous nucleus in two compartments of the hypoglossal nucleus, in dorsal, which is here abbreviated as 12 dorsal and 12 ventral, because it has been shown that the dorsal hypoglossal motor neurons located in dorsal and ventral motor compartments are innervating functionally different upper airway muscles, and the genioglossus muscle innervating motor neurons are mostly located in ventral hypoglossal nucleus. So we have quantified separately in dorsal and ventral hypoglossal the axonal projections derived from sub-C and A7 region, and as you may appreciate here, the image A and C shows the subcerebellous projections to hypoglossal motor neurons, and which is decreased due to the chronic intermittent hypoxia. And of course the A7 neurons here and A7 projections do not show the effect of chronic intermittent hypoxia. Furthermore, we have quantified the effect of intermittent hypoxia on A7 and sub-C projections to hypoglossal motor nucleus in male versus female mice used in our study, and we identified the effect of chronic intermittent hypoxia being more severe in males, decreasing the projections by 82%, and less severe in females, decreasing axonal projections only by 42%. Additionally, we have also identified that chronic intermittent hypoxia decreases the body weight in male mice, but this effect was not observed in female mice. So the take-home message here is that the effect of chronic intermittent hypoxia is significant in male mice, which is telling us there is a sex-dependent impact of hypoxia. The chronic intermittent hypoxia has been shown by other investigators also that it causes the neurodegeneration in noradrenergic neurons, namely in locus coeruleus, and other catecholaminaergic neurons identified in VPAG, which is ventral periaqueductal gray, and different parts of ventral periaqueductal gray. It's rostral, medial, caudal regions, and the VPAG is rich with dopaminergic neurons. So in other words, the long-term intermittent hypoxia used here for 6 months have resulted in degeneration of dendrites in locus coeruleus noradrenergic neurons, which is shown here on the left side of the top panel on the slide, and the hypoxia group in contrast with sham group shows less dendrites of locus coeruleus noradrenergic neurons. The neurodegeneration in these neurons has been identified by using the CC3, which is caspase 3, and this is a marker for cell apoptosis. So the middle image here on the right top panel shows the expression of CC3 in green stained TH locus coeruleus neurons, which suggests the neurodegeneration. Also, the cell counts in dopaminergic and noradrenergic regions of locus coeruleus, here for instance for noradrenergic area, significantly less neurons, suggesting the neurodegenerative effect of chronic intermittent hypoxia on this wake-active neuronal population. Obstructive sleep apnea, as we have already mentioned, is also a risk factor for development and progression of Alzheimer's disease, and this has been also shown in multiple animal studies, and one of them I have included here for today's discussion is that chronic intermittent hypoxia and causes the amyloid beta generation in mice, and the oxygen profile is depicted on the left side here. They, in contrast to our studies where we use 10%, here they use 5%, which is more severe hypoxia, and that leads to the significant increase of amyloid beta deposition in the cortical area. Also on the left side, the bar graphs show the higher amyloid beta levels as measured in brain lysate of chronic intermittent hypoxia subjected mice. Altogether, our studies and others investigators' studies show that brainstem noradrenergic and cholinergic neurons innervate upper airway motor neurons and promote the sleep-related depression of upper airway muscles, which leads to apneic episodes in obstructive sleep apnea patients. As we have just discussed, also obstructive sleep apnea creates a perfect storm of factors that contribute to neurological injury and cognitive decline, and chronic intermittent hypoxia, which is a major hallmark of obstructive sleep apnea pathogenesis, reduces noradrenergic innervation of hypoglossal nucleus and thereby exacerbates severity of OSA. And chronic intermittent hypoxia also causes sleep deprivation that leads to accumulation of amyloid beta peptide, which precedes the cognitive decline, as studies have shown. We are aiming to investigate the impact of chronic intermittent hypoxia on functional and anatomical coupling between noradrenergic and cholinergic neurons, which are identified as key neuronal populations responsible for sleep-related depression of genioglossus muscle during sleep. And we also need to understand fully and study systematically the neurochemical mechanisms and neuronal circuitries that are responsible for the control of upper airway muscles during sleep and wakefulness, and these are the important goals for not only basic but also translational research in obstructive sleep apnea field, and this will inform the future clinical trials as we may successfully identify the new therapeutic targets that will help to develop the personalized treatment for obstructive sleep apnea and prevent the comorbidities associated with OSA and improve the quality of life of this patient, young and aging patients diagnosed with obstructive sleep apnea. With that, I would like to thank my lab, my collaborators, and of course the funding, which has been critical to continue our research, and I thank you for attending my talk, and I am looking forward to hear your questions and have discussion about our research. Thank you very much.